Today's lecture is on jaw and intraoral tumors. معاكم دكتورة نهاد سمير أستاذ جراحة التجميل جامعة عين شمس. هنيجي نتكلم على الجو اريا، لازم نتكلم على البوني اركيتكتشر. احنا عندنا في الكرينيوماكسيلوفيشال سكيلتون في الكالفيولار بون، فرونتال، زيجوماتيك، اوربيتال، نيزل، ماكسيلا، بالاتاين اند مانديبل. In our area في الماكسيلا والمانديبل والبالاتاين بون. These bones contain sinuses. Craniofacial bones contain sinuses. عندنا في الاريا بتاعتنا في الجو اريا الماكسيلا contain what is called sinuses. To talk about any tumor we must know its anatomical أو regional form and its pathological form. يعني هنتكلم عليه من الناحية التشريحية ومن ناحية. طيب لما نيجي نتكلم على التيومرز، الجو تيومرز أو الكرينيوماكسيلوفيشال تيومرز، يبقى لازم نمسكها in layers. In layers starting from the skin down to the bone. السكين تيومرز ممكن يبقوا benign، ممكن يبقوا malignant tumors، ممكن يبقوا هيمانجيوماس، ممكن يكون بيزا سيل كارسينوما، سكويموس سيل كارسينوماس، malignant melanomas. السبكوتينيوس أو الفات تيومرز زي اللايبوما واللايبومايوساركوما، الماسل تيومرز، البناين لايومايوما، المالجنانت لايومايوساركوما، النيرفز، النيوروفايبروماز، كارتليج، الكوندروما، كوندروساركوما. bone tumors are also either benign or malignant وهنتكلم عليهم بالتفصيل. We shouldn't forget what is called by odontogenic lesions. Odontogenic lesions are solid and cystic, benign and malignant وهنتكلم عليهم بالتفصيل طالما هنتكلم على الماندبل والماكسيلاري tumors. يبقى احنا عندنا regional classification بنتكلم على احنا طبعا عندنا الكرينيوفيشال tumors زي البيري اوربيتال tumors او الماكسيلوفيشال tumors اللي هو tumors of the mandible, maxilla, maxillary sinuses, and we shouldn't forget the intraoral tumors. وقلنا هنتكلم على الاودونتوجينيك lesions. يبقى كل دول في الموجودين في الماكسيلوفيشال tumors او الجو tumors او maxillary mandibular tumors whatever كانت التسمية. لما نيجي نتكلم على أي تيومر بنبتدي من أول الهيستوري وصولا بالإكزامينيشن، سواء كان general examination سواء كان local examination. In the local examination of any head and neck tumor, we should talk about the draining lymph nodes, and we should know what are the draining lymph nodes we are talking about. The draining lymph nodes we are talking about is the superficial and deep system. The superficial system زي الباروتيد، زي التونسلز، زي والديب سيستمز زي السبمنتال، السبمنديبولار، الاوكسيبيتال، البري اوريكولار، البوست اوريكولار، والابر والميدل والديب سيرفايكال ليمف نود. swellings of the jaw مش كلهم malignant ومش كلهم benign. في lesions اسمها inflammatory lesions and dysplastic lesions. inflammatory lesions زي what is called by the radicular cysts, it is an inflammatory lesion. What is called by epilis, it is an inflammatory chronic inflammatory lesions. So we shouldn't forget what is inflammatory lesions or inflammatory swellings. Dysplastic lesions يعني pre-malignant lesions that may turn malignant at some time, and of course benign والmalignant والmetastasis. هنيجي نتكلم على الجو تيومرز، الماندبل والماكسيلا. they are classified into either odontogenic or non-odontogenic. أول حاجة هنتكلم عليها odontogenic lesions. Odontogenic lesions يعني swellings of dental origin, dental epithelium أو dental mesenchymal tissue, which are further classified into cystic and solid. Cystic, two cysts, the radicular cyst, which is an inflammatory cyst, and the dentigerous cyst, which is a developmental cyst. And solid, so for example, dentigerous cyst is a cystic, developmental, odontogenic swelling of the jaw. طب والsolid؟ solid are either mesenchymal أو epithelial from the dental epithelium أو dental ectomesenchymal tissue. Dental epithelium is the very famous Ameloblastoma, and mesenchymal tissue is the very famous Cementoma. These are the odontogenic lesions. The non-odontogenic lesions, which are any tumor arising from any area except the teeth, which are also classified into cystic and solid. Cystic, fissural, and fissural cysts. Solid are tumors of origin of any tissue, starting from the skin down to the bone, not including the dental tissue, which are further classified into benign and malignant. The benign malignant of the bone are either osteoma or what is called by fibro-osseous lesions اللي هم الفايبرس dysplasia اللي سمعنا عليها وجاينت سيل جرانيولوما، والمالجننت اللي هو الاوستوجينيك ساركوما وهنتكلم عليهم بالتفصيل. هنبتدي في الأول الأودونتوجينيك cystic. The symptoms of any swelling of the jaw can be either a swelling or asymmetry or cosmetic disfigurement. This is the patient complaint. Or he can come late complaining of manifestations or signs of pressure manifestations, like having a loose teeth, a toothache, loss of sensation, impaired sensation, hard swelling of the bone, or ulcer, inflammatory ulcer, or pre-malignant ulcer or malignant ulcer. Diagnosis is either radiological investigations or biopsy. Radiological investigations including the X-ray, the panorama, the CT scan, the MRI, the angiography. Angiography is important in cases of vascular malformations and hemangiomas. Needle aspiration if it is a cystic swelling, and biopsy, excisional or incisional biopsy if it is a hard or solid swelling. The cystic odontogenic lesions of the jaw سواء mandible أو maxilla. عندنا radicular, which is an inflammatory cyst, commonest cyst. 74% of all cysts occur in the anterior maxilla more than the mandible, causes inflammation, foreign body, decayed tooth. Any source of infection will cause granulation tissue, which accumulate inflammatory exudate, which results into a big cyst. X-ray appearance, radiolucent area, and the treatment, like any inflammation, should be covered by antibiotic, anti-inflammatory, and local treatment, tooth extraction, and curettage. This is a CT showing the inflammatory cyst of the mandible in a CT. This is a patient having inflammatory cyst of the maxilla. Inflammatory cyst of the maxilla, radicular. The other cyst is the dentigerous cyst. Dentigerous cyst is a developmental cyst occurring due to missing third molar tooth or impacted third molar tooth. Result in cyst formation, bone expansion, bone thinning, and cracking or fracture of the bone. The X-ray appearance has unique X-ray appearance, radiolucent area encircling crown of unerupted third molar tooth. This is a CT showing left side unerupted third molar tooth forming a dentigerous cyst. This is a panorama having bilateral dentigerous cyst, and on the right side there is cracks or fissure fracture. These were the cystic swellings. The solid odontogenic lesions of the jaw are two: the cementoma, which arise from ectomesenchymal tissue. It occurs in young age, under 25 years, non-painful, can have secondary infection, hard in palpation, very slowly growing, and very slowly to cause cortical plates expansion. Treatment. The X-ray appearance, well defined, dense radio-opaque with radiolucent halo. This is the X-ray appearance or the panoramic appearance. The treatment is excision. Of course, it is benign tumors, so it doesn't need a safety margin. The other lesion, which is the epithelial origin, is called the ameloblastoma. Ameloblastoma is a hard odontogenic lesion of the jaw, and it has unique appearance in the X-ray. What happens is it is a soft tissue swelling that grows inside the bone with very rapid growth, causing bone expansion and pressure on the root of the teeth, which can cause resorption and falling of teeth and it occurs from the remnant of dental epithelium in the age of 20 to 40 years old, affect the mandible more than the maxilla, and it is a very dangerous, locally destructive lesion that rarely turn malignant into squamous cell carcinoma, but the problem is that it is a very rapidly growing tumor. So we should have biopsy, ameloblastoma, we should do excision, and we must make sure that there is safety margin, but by what is called by fresh frozen section biopsy. It has a unique X-ray appearance, which is the honeycomb appearance. As we said, biopsy is very important to know that the edges are completely free because it is a highly recurrent, rapidly growing tumor. Treatment is excision and safety margin to prevent recurrence, and of course we should do follow-up, and if the excision is big amount, so we need reconstruction by bone graft and reconstructive plate. This is a case of ameloblastoma, painless diffuse nodular enlargement of the mandible with loss of teeth. This is after bone excision. This is the case after bone. Here is another tumor of the mandible taking almost body, ramus, and parasympathetic. This is after excision, and we did reconstruction showed by the panorama by a reconstructive plate and screws. The giant cell lesions. We have finished the odontogenic lesions, and now we are talking about the non-odontogenic lesions of the jaw. Non-odontogenic lesions, we said, include all tissues starting from the skin reaching to the bone. Bone tumors are either benign or malignant. The benign is the giant cell lesions and osteomas, and the malignant is the osteosarcoma. What is the giant cell lesions? Giant cell lesions are either giant cell reparative granuloma, brown tumors, hyperparathyroidism, and osteoclastomas. Clinically, all these lesions have the same symptoms like ameloblastoma. Differentiation is biopsy, and the treatment is the same, excision and reconstruction. The giant cell granuloma occur under 30 years, more in the mandible. Early lesion detection show uni or multiloculated lesion, expansile mass, rarely painful, involving the gingiva or alveolar margin. This is a CT showing the giant cell lesion. Another case after excision, and it required reconstruction by a bone graft and reconstructive plate and screw. The malignant lesion is the osteogenic sarcoma. Osteogenic sarcoma occurs in the age of 20 to 30 years. Swelling with bone destruction, with loss of teeth, with ulcers. The X-ray showing bone destruction or new bone formation with sun ray appearance. It needs a biopsy for diagnosis and for grading, and the grading, of course, is through the TNM classifications. The treatment is pre-operative radiotherapy with excision with safety margin, and the safety margin, of course, is according to the grade of the tumor. This is the case of osteogenic sarcoma with reconstruction and coverage with local flap. Maxillary tumors. Maxillary tumors are either from the bone or from the sinuses. Okay? Maxillary neoplasm classification is either carcinomas like the very famous squamous cell carcinoma, adenocarcinoma, less common adenoid, cystic, mucoepidermoid, anaplastic, and transitional lesions. Sarcomas like the reticulum cell, osteogenic sarcoma, chondrosarcoma, fibrosarcoma, liposarcoma, rhabdomyosarcoma. Odontogenic like odontoma and ameloblastoma. There are also other lesions like the melanomas, lymphomas, Burkitt lymphomas, and secondary metastasis. The very famous squamous cell carcinoma. It's more in males, 2 to 1, occur in very old age, 60 to 80 years, rare below 40 years. It has precipitating factors like smoking, like chronic sinusitis, like squamous metaplasias. The adenocarcinoma incidence is 10 to 20% of sinonasal malignancy, arise from the mucosal secreting cells of the epithelium of the maxillary sinuses. Are either two types, salivary or non-salivary. Salivary is the adenoid cystic carcinoma or the mucoepidermoid carcinoma. Non-salivary is the low-grade or intestinal type. This was the adenocarcinoma. The intraoral tumors. Intraoral tumors, we have several content of the intraoral cavity. The tongue, floor of the mouth, buccal mucosa, the gums, the retromolar trigone, and the hard. Intraoral lesions are either benign or malignant. Benign like the hemangioma, lymphangioma, papilloma, and mixed salivary tumor. And there is also inflammatory lesion like what is called by Ebulis. Ebulis is hyperplasia of the gums due to chronic inflammation. It is a fibrous lesion, responds to local irritation, at first soft, then become red, then firm and pale. Often pedunculated, might ulcerate, might cause ulceration due to trauma during mastication, and usually confused with malignancy of the intraoral cavity. This is epilis at acute epilis. There is other pre-malignant lesions like the leukoplakia. Leukoplakia occur due to chronic inflammation of the oral mucosa due to foreign body or denture. It occurs in old people, smoker with ill-fitting denture. It shows defined patchy areas of keratinization. Intraoral soft tissue tumors are, as we said, malignant squamous cell carcinoma, salivary gland tumors, and others like melanomas and lymphomas. The squamous cell carcinoma, it is two types, either exophytic or endophytic. The spread is through lymphatics to the cervical lymph nodes or distant blood metastasis through the lung, bones, perineural spread through the trigeminal nerve to the brain. Treatment is by, first we take a biopsy, and when the biopsy shows squamous cell carcinoma, we do the grading, and we treat it by preoperative radiation and excision with safety margin.